Okay, welcome everyone as you're hopping on. We're gonna give it a few more minutes while we wait for everyone to get on, but go ahead and just change your name in the chat and add your contact information for us. And I threw up a poll, so if you could go ahead and do that while we wait, that'd be awesome. And then we'll get started here in a few minutes. Okay, I think we'll go ahead and just get started, and I'll keep letting people in as they come. But welcome everyone. We're so excited that you were able to join us for our project scope session. We have a really awesome, amazing presenter and presentation ready for you, so we're excited for that. And like I said, we have a poll up. If you could just fill that out if you haven't yet, and change your name to have where you're from, like what organization you're with. My name's Bailey. Janelle normally does this part, but she's in a training, so you're lucky enough to have me. And we are recording this ECHO session, which I'm sure you heard, and we record it for educational and quality purposes. And by participating in this session, you are consenting to be recorded. So if you don't want to be recorded, please just go ahead and jump off, and you can watch the session later. Oh, I lost my button. Let's see. There we go. And please rename your profile to your first and last name in the organization you're with. There's different ways to do that. You can click the participants icon on the bottom of your screen and do it that way. And if you have any questions, you can chat one of the hub members. They are the ones with the asterisks in front of their name, or you can chat me and we can help you with that. ECHO is an interactive community. And one of the biggest things we do is case presentations. And so we want to create an hour and a half where we're discussing and participating. So we'd love if you could turn your cameras on if you're able to, and you can comment in the chat if you have questions or comments, or you can feel free to unmute. And case narratives are the best way to solidify the skills that we talk about in our didactic presentation. And we always are looking for more case presenters. So if you, I went too soon. If you haven't had a chance and you'd love to present, we'd love for that. And with that, with case presentations and anytime we're talking about people, please just remember to protect their individual privacy and avoid using their real names, their first, middle, or last name, and not identifying any of their family members or friends. And if you are unsure about that, you can reach out to a hub member. Again, they have the asterisks in front of their names. And so the key components of an ECHO session is that it's a community of practice and sharing that knowledge and helping each other learn and sharing resources. And so we do that through the didactic speaker and a case presentation and feedback. And so at the end, if you could just comment in the chat, one reflection from the session and one thing you might add to your practice, that would be awesome. And we are this is the last project scope session of 2021, which is crazy. We're gonna be starting our third, I believe it's third network in 2022, and that's gonna be starting in March or April. So be on the lookout. You can start to pre-register for that. by going to our website or emailing projectscope@usu.edu. And you do get credit for attendance. You can earn professional development credits by filling out the evaluation that will be sent to you after you attend this session. So that's an awesome thing to do. And I'm going to turn it over to Michelle now to talk about CMEs.
Great, thanks, Bailey. So CME credit is available for today's session and must be claimed by today, no later than midnight Mountain Standard Time. And the code for today's session is 349195. And I'll also throw that in the chat. And please watch for an email from me this afternoon with instructions on how to claim the credit. Nurse contact hours are also available by completing a survey. The survey link will also be in that same email I will send after the session. Thanks, Bailey.
Okay, thank you. Okay, and then Canvas and REDCap. Canvas is a platform we use where we share all the resources we talk about in our sessions. We put the video recordings of the sessions and any other information that you need, we put it on Canvas. And so if you would like to be on our Canvas page and you're not, go ahead and email kurt.phillips@usu.edu or projectscope@usu.edu. And we will be starting a new Canvas page with the third scope platform. So be on the lookout because that invitation will be coming in your email. So you'll need to re-register for that one. And then REDCap is is a data collection / analysis tool we use with Scope. And so you will get surveys from that. And so make sure you check your spam or junk mail folders for that, because those surveys are very helpful for us to know how we can improve these Scope sessions for you. We want to make sure it's the best we can for you. And just one last plug for case studies. It's a great way to get feedback and ideas for cases you might be having, or to just share information about real life situations and help each other. And then here's our social media, where you can get all the information about upcoming presentations and links for things. Yeah, so we're very excited for our presentation today. We have Pat Boyle that's going to be with us. And so I'm going to stop sharing and turn the time over to you, Pat, if I can figure out how to do that.
Okay, so I share screen, right?
Mm-hmm.
Oh, that's not the one I want. Ah. All right, stop share. You're gonna have to bear with me.
We're all just doing our best.
Yeah, well, I said I am much more at ease treating children than talking. Okay, slideshow. Oh,
yep, go back to slideshow and press play from start.
There we go. All right.
Perfect.
So good afternoon. My name is Pat Boyle. I'm a pediatric physical therapist, and I have been in practice for almost 45 years. So I've seen a pretty interesting spectrum of child who has been prenatally exposed, both in the NICU. I've seen them and then follow up in early intervention. So that being said, I do work PRN at Primary Children's, Intermountain. I get called to Heber, Park City, all the other Intermountain hospitals. And then I am a consultant in feeding for DDI Vantage. And I do see some children with motor issues. Anyway, my objective for this is that we all need to understand the unique assault that prenatal exposure to opioids has on the developing fetus and infant's sensory system. Their senses are overwhelmed, and that includes their hearing, their vision, taste, smell, vestibular, proprioception, and touch, and all the touch parameters. And we just think about touch, but we don't think about deep touch, light touch, pain, temperature as being painful and or not tolerated. I also would like to have you understand how that infant communicates when their sensory system is overwhelmed. By either being under responsive to the input, over responsive, or seeking more of that input, which is your sensory craving. And then finally, define how being overwhelmed in an environment that has excessive sensory input can cause developmental delay. So NAS or NOWs, opioids, I'm sure you're all familiar with prescribed pain medication, which I've recently been through. Your opioids, your codeines, your Tylenol 3s, then prescribed medication for chronic pain, which includes methadone, Suboxone, and then finally your street drugs, heroin and fentanyl. The opioid receptors are concentrated in the central nervous system and the GI system. The half-life of the opioid is significant in the timing of withdrawal. So heroin can occur within 24 hours, while methadone can take 24 to 72 hours. And that is the conundrum that faces most level 1 nurseries, is why is this baby the way they are? And if there's early discharge, then you don't know. The baby will withdraw at home. And they can continue to withdraw over the next 6 months. And then what has a lot of us just not understanding this process is how poly drug use can confound the weaning process for the infant. You think, oh my gosh, they're not demonstrating signs of withdrawal anymore. We're going to withdraw our help, and then they're sent home and they continue to have significant issues with withdrawal. So the CNS responses include excessive irritability, you get your high-pitched cry, your hyperactive reflexes, which are your grasps, moro, and suck. They can become tachypnic, tachycardic. They can have hypertension, sneezing, yawning, sleep disorders, sweating, hyperthermia. They can have unregulated eating, which is they eat too much or they're not eating enough. You can have hypertonia, tremors, seizures, and you can have death. The GI responses include excessive weight loss, diarrhea, vomiting, poor motility in the GI system, and then skin excoriation with the excessive diarrhea. Infants who are withdrawing are unable to interact with their environment, depending on the severity of their withdrawal, which as a developmental therapist is very concerning to me. So you get your normal or your typical child. They're born full term, and they exhibit what I like to call smooth interactive control over their subsystems. And these subsystems include your autonomic or physiologic stability, which is your heart rate, your respiratory rate, your saturations, your GI system in terms of signaling, digestion. You have motoric stability, the typical. Full-term baby is flexed, but they have nice smooth movements as they move through against gravity. State regulation, they sleep when they need to sleep, they transition smoothly into an awake state. And when they're in that awake state, they will give you eye contact. They might smile. They are responding to visual and auditory input, and that's their interaction. And then the self-regulation is putting it all together. I mean, they can keep their physiology stable, they can smoothly transition into an awake state, and then they can engage with eye contact and smile. Opioid exposure. An infant who is exhibiting signs of withdrawal is unable to attend or interact or regulate their physiology, motor, or state systems. They need help in all areas of their development, but most specifically, their sensory system is raw. It's overstimulated and needs to be protected. So I listened to a presentation a year ago, and I've also listened to Camille Fung's presentation. And they are trying to do this ESC program at the U in their nursery. But this is Dr. Scott Wexelblatt. He is in Ohio, and he looked at 3 screening methods used with infants exposed to opioids. The first is the Finnegan, which has 21 scoring items. And I've certainly gone through it with children and helped nurses learn how to do it. You get the simplified Finnegan, which has 8. And then finally you have Eat, Sleep, and Console, which has 3 parameters. The Finnegan requires admission to a nursery or a NICU, and the scoring is every 3 hours with titration of meds to help withdrawal. It's the traditional approach used here, and that's what I'm used to in all the NICUs I've worked with. And I do not work at the U. And I know on a limited basis, they're trying it at LDS Hospital. But basically, we bring our kids into a special care nursery or a NICU, and we score them and titrate their meds. And then the Eat, Sleep, Console requires rooming in with parental presence. The focus is on the infant and mother dyad, and the focus is also on encouraging breastfeeding if they're allowed, skin to skin, good environmental control. And that environmental control is not a change of caregivers every 12 hours. The caregiver is the parent. And so that's where a lot of this has power. And some of them may require pharmacological help. It has simple parameters. They implemented it over 11 Ohio State Hospital. If the infant is able to eat, sleep, and be consoled, withdrawal is accomplished. If not, they will intervene with meds. If there was 100% parental involvement, there were 8 fewer days of opioid treatment, decreased NAS scoring, and a 9-day shorter stay. So a 9-day shorter stay in a NICU costs is a lot of money. And the moms who were on methadone were allowed to breastfeed. And typically, the moms that I've seen on methadone are usually receiving it for pain management, and they're getting a very consistent dose of medication every 3 hours or every 6 hours. I think it's a long term, but I don't know much about it. But this is a statement by the American Academy of Pediatrics in November of 2020. Across the country, pregnant women lack access to evidence-based therapies, including medication for opioid use disorder, and infants with opioid exposure frequently receive variable care. There is no standard of care for these families. I've been involved in family-centered developmental care in the NICU for years, and I've also been in early intervention for years. And our children and the family is the focus in these environments. It's time to have a more comprehensive approach to the management of infants with NOWs and their families. And if any of you listened to Camille's talk in October, it's only going up. Our families are only getting more involved, and our babies are getting more exposure. So it is time. So what's affected? With their vision, which is a very underdeveloped sensory system until birth, they are overwhelmed with light and visual input, and therefore they're very hypo-responsive. You will get a lot of these kiddos, they won't give eye contact. They might focus on lights, but they really do get overwhelmed visually. Hearing again is overwhelmed. They've been able to hear since 23 weeks of gestation, but it's muffled, and it's generally, who knows, given a chaotic environment, what they have been listening to, but it has been a muffled system. But it is hyper responsive once they are born. Taste and smell, they're overwhelmed with the input, the smell of hospital blankets, the smell of multiple caregivers, even the smell of formula, if they're being offered formula. It's a sensory input that's typically getting mature at around 16 weeks of gestation, but it's very mature when the children are born, and it can be overwhelming. Vestibular, they have hyperactive responses. It's a mature system in utero at 30 weeks. However, the preterm infant cannot use flexion because it hasn't developed to modulate once they're born. Our prenatally exposed infants, our NAS babies, our NOWS babies, don't know how to react to movement except with a hyper response. So again, it's they're hyperactive or hyper responsive. They're overwhelmed with touch, with cold hands, light touch, stroking touch, looking for an IV. You know, the tactile input that goes through, just looking for an IV, diaper changes, clothing changes after vomiting, and the pain. They can have pain. It can be interpreted as pain just by inserting an NG tube or rubbing and patting, all the things that we do to try and help calm children. And finally, proprioception. And proprioception is giving that deep input through our arms and legs and trunk. It's weight bearing, and they're not given enough, and they're definitely seeking it. When an infant is withdrawing from opioid exposure, all areas of development are affected. So in terms of your motor, they do not demonstrate smooth rhythmical movements of arms and legs. And way back when, we just knew. But now in our NICUs, our level 3s, they're doing the general movements assessment on these babies. And I don't know if you all know what that is, but it is scored. And they can be scored to be high risk for developmental issues, specifically cerebral palsy. Their head control and trunk control are limited by increased tone and tremor. They're unable to bat at overhead toys, bring their hands to their mouths, or engage in self-soothing with their hands and bodies. In terms of their language, which is your vision and hearing, they're unable to participate in smooth visual pursuits, give eye contact, attend to parents or caregivers' voices, smile, or participate in vocal play. And if you just think about a really intact little 3-month-old, you know, they're giving you great eye contact. They're doing open-end vocalizations. They're trying to bring their hands together. This does not occur when you're overwhelmed. Cognition, anticipatory excitement, visual and auditory attention are impacted when the infant's sensory world is overwhelming. They don't know what's coming at them, and they either cry or shut down in terms of that there is no anticipatory excitement. Your adaptive, which is your feeding, your sleep, the self-regulation around hunger and satiation are disrupted. Sleep is disrupted. You have smooth coordinating sucking responses to a filling tummy, and that's dysregulated. Social self-regulation is only obtained when held tightly, swaddled with supports. So these kids cannot come to even a calm, alert state unless they're given a lot of external supports. So they're unable to explore their world or approach their world socially when the sensory constraints are limited. Given the impact on development in the first few months, the infant may continue to demonstrate developmental issues. So what do we do in our NICUs, and what do we encourage the families take home with them? Vision, no bright overhead lights. We want diffuse light, and we want dark for sleep, and we want skin to skin. In terms of hearing, we want quiet, modulated voices, soft voices, humming, shushing, silent for sleep, and skin to skin. With smell and taste, you want the same person, the same smells. You want the regular formula or breastfeeding or skin to skin and skin to skin. With our vestibular or movement system, we want slow, predictable movements, rocking side to side, deep pressure with movements, and we want to combine proprioceptive input with predictable movements. And the caregivers know what triggers their child to be out of control. And again, your skin to skin. With tactile, we want our cares and or our diapers or dressing activities to be slow and predictable. You want to put the baby in a flexed supported position. You want warm hands, and my hands have never been cold. I've got some of the warmest hands a therapist could have. So I think babies always like me. And then I feel some of the parents' hands and they're ice cold. And it's like, well, the baby is going to get used to that one, hopefully. So we want no patting, no stroking. We want to introduce massage with oil, massage strokes that are firm and predictable. And then finally, skin to skin. In terms of our proprioception, we want lots of swaddling, deep pressure, and again, skin to skin. Are you getting that skin to skin is really important? The baby's safe in skin to skin, very, very safe. So how do we transition home to discharge? So infants with NOWS are discharged home with early intervention follow-up in the community. I know that we refer all of our infants who have been in our NICU to follow up early intervention. The family-centered EI should focus on routines in the home and ongoing support of the family and the infant within the context of those routines. Recent discharge teaching, I did, the infant is ready to go home off the pharmacological support for 48 hours. However, these babies are still very sensitive. They may still have a lot of residual high tone. They've learned how to cry with everything. And so they can be incredibly irritable little babies. So the sensory rules for them are that proprioceptive input, vestibular input, and tactile input can be a powerful communication tool. So if you give them deep containment, you move them very slowly with firm, warm hands, the child learns that they're going to be safe. When it's used in conjunction with activities of daily living, they can provide the connection, the foundation, and the building blocks to effective communication with the fragile infant. So the infant and the parent are in sync with each other. The baby knows the parent is not going to do anything to stress them. The parent knows that when I do this, my baby is not stressed. So the other 4 sensory systems must be used very cautiously. We don't want to pair looking at our baby, bouncing our baby, talking to our baby while we feed them. That's 4+ sensory inputs. We want to perhaps hold our baby with good containment and feed, and maybe doing some shushing, but no moving, no input. You want 2 sensory inputs at a time initially. That allows you to interpret. So if you're doing 2, if you're doing firm proprioceptive containment and feeding, and then you sneak a peek to get some eye contact and the baby tolerates, or you start humming or talking or singing while the baby tolerates that third, they'll let you know. So don't try to rock, engage eye contact, talk and feed at the same time. And always remember that firm containment can bring the kiddo back to baseline. So your sensory rules are: vestibular input is both powerful and dangerous. You only move in one direction. And if you can think about how the inner ear is, side to side movement does not stimulate the vestibular system in an overwhelming manner. When you're sitting in a rocking chair and you're going back and forth, you are overstimulating that inner ear vestibular system. So you want most of your movement just to be side to side. So that's why I hate rocking chairs in NICUs. Watch out for visual and auditory overload. You don't want to use multisensory toys with lights and noise, just some soft wooden toys that rattle quietly. When working on feeding, evaluate how many other systems are being activated. And finally, save your perfume and cologne for someone who really loves you. And this is, I'm talking to you as the EI and or NICU specialist. So the big thing is about waiting. So you want to give the input, and you want to wait for the subtle signs that you have made a connection and a communication circle has been initiated. If I were to slap you across the face, you would immediately respond and slap me across the face. You and I have frontal lobes that are intact, and we will respond very quickly. However, if I do something to an infant, number one, they're immature, and especially if they've been preterm, that sensory information takes a while to come and process. So you want to wait, you want to do something and oh, they don't like it. No, well, in about 5 minutes, they do like it. So one of I think that the most important things is that you need to be patient as a caregiver. You need to see whether or not what you're doing. So massage is a beautiful example. I always start with the foot, and I just do slow massage strokes on the foot. And I wait and wait and wait. And eventually the kiddo says, I hate it or I like it. And we go forward. You want that parent to have that wait strategy. And that's hard when you're working with a family member who is in their own journey of withdrawing as well. There's a lot of impatience. There's a lot of guilt. There's a lot of whatever. That's why I love massage. I love teaching families how to massage their babies, because I get them to do the strokes my way, which is very firm and very slow. And it has a very calming effect on families when you can work with them on massaging their babies. And the other thing I find is I do what's called hand over hand facilitation with the parent. So I'll show them how to move their baby with my hand on their hand as they're moving, and we'll slow it down, and I'll show them exactly what that wait protocol is all about. So how do we make the communication connection? It's consistency and repetition. When a child's world is consistent and predictable, they trust. That trust builds into the bridge to consistent, connected communication. And that's why we work with parents, because that 12-hour nurse may love that baby to death, but she may not be back for 3 days. So that's why parents are huge. And again, also with our EI specialists, we might not be back for 2 weeks. Okay, skin to skin, infant massage, swaddle bathing. I love to dress infants, even a tiny infant, in sitting, because they're not getting that overwhelming input of having something pulled over their head. I've changed diapers when the baby's been on their belly. I always transition to a flexed side-lying position, into and out of the crib, out of the car seat. Anytime you pick them up, I want them side-lying and flexed, because you're helping them stay flexed, and you're also giving them pretty good boundaries as they move that vestibular system through probably a challenging movement. So this infant that I'm about to show you was prenatally exposed to methadone. His mom gave me permission many years ago to film. She was on methadone for pain. Prior to the initiation of daily hydrotherapy, he had increased tone, decreased extremity movements, and he did not smoothly transition to an awake state unless bundled. His sucking was excessive and interfered with a calm state. So let's pray this works. Everybody's praying. Okay, so here's this little man, and we've started doing hydrotherapy with him, but just watch his face. He's a full-term baby, and he doesn't know what gravity's doing to him, and he's very irritable with this excessive movement that he can't control. And so I'm about to show you his tone is a little bit better than it was, because we've been doing a lot of swaddle bathing and movement in the swaddle bath. But his behavior, his state is out of control. We're talking to him, his eyes are tightly closed. It's not that bright in our rooms. I think there's daylight coming through. But then we re-swaddle. Okay. And I go to check the water, and somebody else comes in to give him a little bit of containment. So he's still excessively sucking, trying to help himself with his hands, but not really understanding how to give himself some help. And just give me my pacifier. So I'm about to take him out, and we're going to do a swaddle bath. And I leave the leads on in the hospital in the hopes that the gel will expand and just slide off. So we're going to have him on his side. and do that transition. How many of you have bathed a newborn baby? It can be a daunting experience, especially for a family. So I like this handling strategy because it keeps everybody in control. So I bring him on his side, flexed up against my chest. And he's like, okay, fine. Is this anticipatory to what's happening? I don't know. But then just watch what happens to him once he gets in the water. It's almost like somebody gave him a little bit of a drug. He calms down. I mean, as this progresses, his facial expression changes. He becomes a little bit more tuned into his extremities. So I always put them on their side in the bath, swaddled, and then gradually unswaddle them. So I start with the legs. Nurses like to start with the heads. I start with the legs, but this is swaddle. This is hydrotherapy. This is not a bath. And that's where I'm going to do. And so he's got a little bit of an ooh face. I mean, he's sort of saying, oh man, okay. So this is powerful stuff to show a family. And I know when you're discharged from the NICU and or a hospital, they talk about limited bathing, and that's because of this exposure to soaps. There's nothing wrong with water. You can put your kid in water anytime you want, and then follow it up with a nice massage. But look at his beautiful little eyes. He's processing, he's interpreting, he's saying, this is okay. And I've taught his mom how to do this, so it's even better when she does it. But he's nice and relaxed. He's got that sitting on air sort of tenseness in his legs, like what's going to happen next. If you were doing this with a full-term baby, there would be a lot more flexion. So now we head over to his arms. And before, this would have not worked. He would have, as soon as his arms were let go, he'd go crazy. But he's learned that this warm water feels good. So I do this for about 10 minutes with the baby, and I incorporate range of motion and some massage that you will see later. So he looks pretty good. He says, this is not bad. So one of the major things I've noticed as a therapist through the years is if children spend a lot of their time doing that extended arm, get away from me, their forearm is in pronation. And even though they don't actively supinate until they're about 8 months, they can get real restrictions because they're hyper pronated. So I think I'm going to do it here. I do active range of motion in the forearm, and that's for the therapists out there. But he's getting a lot of movement. He's getting a lot of changes. He's getting unbundled, and he's just not losing it the way he was losing it when he was on the surface. So there I'm doing a little bit, but he looks pretty typical right now. I mean, he's getting his hands up to his face. He's going to smile a little. Yeah. Okay. So I think I'm going to get this a little faster because I do some massage here.
Pat, as a pediatrician who works with a lot of babies in withdrawal in the nursery, I feel like I'm watching magic. Like, this is almost making me cry. It's really lovely. Thank you for sharing this.
Oh, you're so welcome. I mean, this is magic. And now I'm getting into his lower back and doing a lot of pelvic mobility because these kids get so stiff. And he's just, I mean, can you imagine you as an adult with somebody just doing this beautiful movement? I mean, he's relaxed, he's calm, and then we can do some massage. And I love swaddle bathing, and I don't do it as much anymore because I can't carry the tub. I can't, obviously, but there are so many therapists in our NICUs that are doing this. So this is a very this is a therapeutic strategy to help with withdrawal. He's experiencing a body that feels okay for a change. And so I don't know how much time I've got. I wanted to keep this to 30. I think I'm almost on the cusp here because I've got the case study. So the leads should by now be full of gel and just slide off, unfortunately, with him. So what I think is important is to notice I'm pulling off the lead as I get further up, and he's still like, this is great. This is fine. So this has helped him figure out how to get calm. And so that's pulling on his skin, and he's like, it should have been full of gel. It should have been easier to come off. But he truly does. And then he's grabbing for me and says, oh, what are you doing to me? I mean, these are all nice little responses with this from a baby that was pretty out of control prior to. So we're going to get him out. And I do the same thing when I get him out. I have a warm, towels are terrible in the NICU. They are rough and they stink. So I use blankets that are warm, pull him out, and he's like, ooh, I don't know about that. But then it's an immediate, you're in a warm blanket. We're going to dry you off. And everything is flexed sideline. So we're heading over to the bed. And this is an old NICU. You can tell the swings aren't the ones that we have now, the $150 swings that turn and spin. So another warm blanket, get him out of the wet stuff. And he's like, oh, I don't know if I like this, but why would he? He's now cold. But again, this is the only time I'm fast is to try and transition into something warm. We give him his passy, and I do my sideline diaper change. And yeah. So he looks pretty content right there. The other thing was his respiratory rate. I was going to point that out. The very first part of the video, he was tachypnic in anticipation of whatever I was going to do. So Mom knew how to do this. She'd been taught all of these strategies. And as time went on, he showed less and less of the hardcore things that worry me as a therapist. So I'm going to slide ahead. And I checked his tone, and it's a little bit better. I wasn't going to put leads back on him, but the nurse said I had to have a sat monitor on him. So then we are ready. So I'm just trying to see how, yeah, he's still got that sort of sitting on air, sort of tightness, but he's not as frantic, I think, as he was before. And he says, I didn't like it that you lifted me up so fast. Oh. And then we just feed. And he does a really good job once we get down. And I also want families to feed. If they're going to bottle feed, I want the baby in what we call a breastfeeding position, which is elevated and on their side, which helps to promote better oral control. And look at, he's bringing his hands to his mouth, and he's rooting, maybe appropriately, I don't know. And then we turn him over. Yeah. And there he is. Okay, so I do, my references. Heidi Elise Alls with her synactive theory of development. Okay, gosh. Oh, I just clicked it. Anyway, you've got the slides. My mentors, the children that I've seen for years are my mentors. Okay, so do I hit stop share and go to the case study, or do we wait for questions or what?
Yes, we can take questions first before we do that. So does anyone have any questions for Pat? You can either unmute or you can put it in the chat.
That was really incredible to watch. Thank you for sharing that video.
Oh, you're welcome. I mean, I do this, I've done that for decades, and I usually have the parents take over, and they always do a marvelous job, and they carry that home with them. I was once in a staff meeting at LDS Hospital, and this woman was being wheeled to labor and delivery, and she said, "Stop." And she yelled at me, "You taught me how to swaddle bathe my first baby. It's miracle. I tell everybody about it." And so there was some generalized behavior, and her baby was fine. I just showed her how to swaddle bathe. But it's a therapeutic technique that we all need to do with our babies. So yeah.
So does anyone have any other comments or questions for Pat?
I do real quick. How does one get trained to do that? Does it require specialized training like infant massage?
I don't know. We have to bathe our babies.
I know. I was just curious if it was specialized training, or is it something I could just watch the video over and over and kind of learn your technique? And
Well, I think the key takeaway is that you want a 10-minute bath. The temperature of the water has to be 101. What else? I don't like Johnson & Johnson products. There, I've said it. I like glycerin soap or something. I mean, babies aren't dirty. They don't need a lot of scrubbing. If you keep in mind the flexed side into the tub, out of the tub, back onto a surface to dress. I mean, I have taught obviously hundreds of families how to do this, and they go home and they develop their own technique. You know, they will come to me and say, well, now he doesn't need to be swaddled. I just put a face cloth on his belly and he's totally fine. So I think the idea is that it's not a task, it's a therapy. And we all have to bathe our babies, so.
okay.
Awesome. And there's a few comments in the chat. Pat, I don't know if you saw, but Marla said, amazing to see that baby's reaction. And Wendy said, it would be good to show all moms this. So many, especially first-time moms and dads, are fearful and just don't know what to do.
I agree. I agree. I've done this. I went to the home of a child. He was about 8 months. He was in foster care, had been horribly prenatally exposed. His birth history was, he'd been dropped at the ER with his umbilical cord still attached. He sustained tremendous brain damage as a result. He ultimately was G-tubed and trached. But the parents, number one, was he hates his bath. He hates it. He hates it. He hates it. So I brought the biggest tub I could find. I brought the biggest sling I could find, and I hoisted this 15-pound baby in and out of a swaddle bath, and he loved it. So this is a tech. So my base is children with special needs, children who have developmental issues. And so how can I keep them from getting out of, control? And so this little boy had severe spastic quadriplegia. He did great. So it's a good technique.
Well, I think if no one has any other questions, we can move on to the case presentation.
Okay, so I go to share screen again.
Yes.
All right. It's not there. Okay, I'm going to get out of share. Am I still allowed to share?
You should be.
Because I don't see any of my stuff.
Oh, you just shared your didactic presentation. So that works. So you're still able to share.
Okay, well, I'm going to go see if it's open. I'm sorry.
Oh, no, you're okay.
I don't know where it is. Zoom us. Yeah, this is not working. End of this. Oh, I guess because end of the slideshow. Click. Do I skip? Escape.
Yeah, click escape and you can close that first presentation.
It's not exiting. Jeez. Escape. Click to exit. Okay, there we go.
Got it.
Yep. And then that one's open. So now I go back to you guys. And I do share screen again, right?
Mhm.
There she is. All right.
Perfect. And we can see it.
Okay. So this is my case study. And there's me again. I don't have any disclosures. And so my objectives for the case study, whoopsie, is that you appreciate the evolving needs of a baby or a child with NOWs. And why are all these people here? Okay. Anyway, sorry. This is crazy. Okay. And NOWs and the family. So how do we as providers advocate for resources and facilitate access to those resources? And how do we stay connected to families through foster care, changing address, changes in your DCFS workers, and the moves that the families go through? Okay, so oh, I see, I can move me. Oh, no. Okay, I can't see my screen. Why is that?
You can't see the presentation.
No. So I think if I edit no, that's not happening. How do I get all of you off my presentation? I don't know what I did before.
There might be, I'm not sure what you're seeing on your screen, but if you see a tab that says view.
Yeah, no.
No. Is there?
Okay, I'm going to just pull you guys there. You're at the bottom. Okay.
Okay.
Okay, so my case study is okay. There we go. She is a 26 or was a 26-week gestation baby, Jay. She was born to a 28-year-old G2 P1 mom with a history of polydrug use. Her previous pregnancy, she has a 6-year-old with no exposure in custody of the father. The mom knew she was pregnant. She'd been on a drug binge and then snorted cocaine and had a placental abruption. She required emergency C-section at 26 weeks. Both she and the baby were critically ill. They both almost died because of the exposure and the abruption. So let me see. So the baby had a long course in the NICU. She was 26 weeks. She was from an abruption, also prenatally exposed. So it's just one of those, what is it? She was diagnosed with PVL. She had head bleeds. They told the family that she had a 60% chance of cerebral palsy. She had high tone. She had tremors at rest. She took a long time learning how to eat and probably went home at about 42 weeks of gestation. DCFS was involved with the mom. And this was amazing because the mom had a massive turnaround in the hospital. She enrolled in, it was an in-house drug rehab. They were very involved with her, and she was to be discharged to the in-house rehab with the baby when the baby was ready. And so I was asked to meet with the family in the NICU. I did a transition IFSP there, and the baby and the mom were discharged to the halfway house. So to couch this, the halfway house had a ton of rules. They would not let me go to her bedroom to work with the baby. I had to meet the family. They had a school or a housing school down the street, and I had to go to the gym to meet with this baby. And she was a mess. She was a mess. She stopped eating. She was totally overwhelmed, so in this gym, people would just come in, and I'm trying to work with this little girl. And so I eventually had to meet with the people who were in charge of the halfway house. I said, she can't follow the rules of your other residents. I don't want her going on field trips to the zoo. She was a 26-weeker with bad lungs. I don't want her going. I don't want anybody else to be feeding her, because they said, oh, well, we'll feed her while the mom goes to her classes. And it's like, no, this mom needs to be in charge of her baby. So we eventually got to the point where I was able to see the baby in the mom's room and work with her issues. And then mom, I guess, got fed up and left the program. But she knew that she would have the baby removed if she didn't immediately find support systems, and she did. So she was discharged home, or she went home to her daughter's father's house, and that's where she's been. She initially had very poor eye contact, noises, smells, and bright lights were very overstimulating. As we worked with her, she had a difficult time transitioning to purees. She eventually was eating a bottle well. However, any kind of texture, transition to a different kind of cup or straw, she was very difficult. She didn't tolerate movement. Rolling had to be done. She would frighten herself with her own movement. So I pulled in this is the transition, the flex side lying into and out of the car seat, onto the floor. She eventually sat at 10 months. She crawled at 12. She walked between 15 and 18. But I do remember, and the child's quite old right now, but I do remember she always had trouble stepping off curbs. She had uneven surfaces she had issues with, and she could not jump for the longest time in one place. So is it vision? I don't know. I think it was sensory, because she was fully vascularized by the time she went home. I really do think it was sensory. All of these take me out of my comfort zones. However, by the time she was 33 months, she had totally appropriate, receptive, and expressive language. The interesting thing about her was that certain toys, a routine change, and I have vivid memories of trying to do developmental testing with her, where you're taking the toys away all the time. You're not allowing her to play with those blocks over and over again. She'd lose it. She would have historic temper tantrums, and they would go on for hours if something bothered her. What was interesting is she loved coins, and she loved filling a piggy bank over and over. And when she was flooded and out of control, if you gave her this piggy bank, it calmed her down. It's like fans will calm down a lot of our kiddos who get out of, who have a lot of regulation issues. So it was pretty clear by the time she was 30 months, she had severe behavioral issues, and our typical behavioral interventions, timeouts, switching out the toy, nothing worked. We got a behavioral specialist involved, and she was referred to the Children's Center and was eventually diagnosed with autism spectrum, as well as sensory processing disorder, and intensive therapy to ameliorate that was begun. So the family, they were a loving family, but they had a lot of issues. Mom admitted that she'd slipped with her sobriety journey with alcohol. She never did go back to drugs, but she had a good sponsor and a good support system. Her partner and the older siblings were at times had their own issues, and it was life. It's just life. She's now 11, and she's in regular ed with support. And she was one of the 100% cohort that had 40% no CP. So the original CP diagnosis didn't pan out. All of what we were seeing was a response to her early gestation, it was sensory, and her mom was so tuned in. So as a provider, and this goes across to today, I've been frustrated by the supports the families I serve receive, from housing, counseling, money for gas or taxis, to transport their fragile, sick infants, to doctor appointments, collaboration with medical and EI programs, and communication. It's a hard journey if you are a provider of service for these families, and you need to do follow-up. I had a little one not too long ago. Her first baby was horrendously exposed to who knows what. He had profound developmental issues, and we were trying to work. And her issue was that she was getting all the therapy she needed, but she had run out of gas, so she couldn't go to Shriners with her baby. She couldn't get, and just trying to access those services. I know there's systems available, but she was not a good advocate for herself. She then admitted that she was pregnant, or thought she was pregnant again. And I said, have you been to a doctor? She hadn't been to a doctor. And I said, well, you need to confirm whether you're pregnant or not, so you can get in and start getting some help. And she did not have the ability to move forward. And I'm a physical therapist. I was there to see her child for physical therapy and feeding. So as providers, I believe we need help helping our families. And finally, this is the number one point, is finally the babies, toddlers, and children, their right to a safe, consistent, predictable, supported, loving environment is more important than any parent's rights. And that's where I draw the line. If you're going to provide your child an unsafe environment, if you are going to continue to not be sober, it's my right to facilitate your child's rights. So that's it. So those are my references. Okay. All right.
Perfect. So we will now we're going to stay in the big group for our group discussion. So we'll just have a discussion about that. Pat, did you have any specific questions?
Well, I know there's some DCFS participants, and I think one of my biggest issues is we're all in this. We're all a team. It's not linear. I mean, I know you're taking care of the parents' compliance with, being clean. And I think we all need to team. It needs to be a team.
Yeah. Awesome. I think that'd be a great discussion to have on how we can, because there's so many different providers and different organizations on this Zoom call. So maybe we can brainstorm some ways that we can better work as a team or access those resources. I don't know. So if anyone wants to put in the chat or unmute, feel free. And Pat, Tressa, put in the chat if you can share your contact information. If you'd be okay doing that.
Yeah. Well, so
Hey. Oh, sorry. This is Sarah Peterson with U of U Pediatrics. I'm just wondering if I could share an experience that I thought was really successful with a really difficult case.
Please.
And I think as far as teamwork goes, what was really stood out to me with this one, and I know it's probably not like logistically possible very often, but in this severe case, the caseworker would come with the patient and the family to the appointments. I was their primary care doc, and that just helped facilitate the team communication like tremendously. So I don't know how logistically possible that ever is, but anytime that like face-to-face or even phone conversations can happen, it just really helps like make those connections and establish those team relationships. So I really respected and appreciated that caseworker was somehow able to work that into her schedule. I think she was actually with the road home, helping like a family that was in and out of shelter. But that was a really, really exceptional situation where teamwork was just really awesome. So that's just my 2 cents there, but phone calls are also super helpful as well.
That's awesome. Thank you for sharing that, Sarah.
I have a little guy that's in foster care right now, and I'm really happy about so his caseworker through DCFS, I think, is the one that facilitates, but we have meetings at least once a month, and she tries to involve everyone that's involved with the child. So I'm the early intervention specialist, but he's also involved with the children's center. The child is, and then like doesn't necessarily invite the pediatrician, but the parent, the foster parent, mom's recovery folks that, you know, help support her. So there's a lot of support people involved, and the meeting gets scheduled for the next month before the phone gets hung up, which I appreciate that immensely. And I don't know that everybody's on the same page all the time, but I really think the fact that everybody's communicating is really helpful. So I think that's really a good thing. So anyway, and like I said, it can be really difficult because I think some social workers are really good about it and other social workers are not as good about it. I've had some in the past that have invited me and some I've never heard from. So, you know, it just depends, but and it's not necessarily just the kids in foster care, but it would be great if, you know, I think I'll support people that work with one particular child if we know about each other. If we have the parents' permission to speak to other providers, I think that can be really helpful too. So it's kind of my input into that. So.
Well, and Debbie, I'm really glad that you said with the parents' permission, because I think sometimes that's one of those things where, yes, some caseworkers are better than others. We will own that as a division. That's just human nature, unfortunately. The other big difference that sometimes people don't understand and can be a little frustrating is when the child is in foster care, the state legally can invite whoever they want.
Right.
When the child remains in the custody of the parent, we can't without that parental permission, just the same way as you guys can't. And so sometimes, depending on, you know, not a lot of people are proud to be involved with DCFS. So a lot of people don't want to tell the rest of them. And so we try really hard to encourage, for your kids, it is worth this coordination. But sometimes that can be a little bit frustrating from an outsider view of like, well, why wasn't I invited? And we're trying to get the parents' permission to have you here, but if they don't give it to me, I can't have. And so that can be a little bit of a barrier too.
Yeah,
but I think the more we can.
I realize it's not just you guys, it's across the board, you know, because it's the same for me as an early intervention provider. You know, some of us are better than others about trying to get permission to speak to outside therapists and other people involved with the child. And I realize that that's the same, you know. But.
Right. And I think, I mean, as a system, as we work together and really kind of have those experiences where the teaming together and getting, you know, coordinating has that positive experience, it becomes a lot, you know, word of mouth is powerful. And the more that we do meet and team in meaningful and productive ways, we can kind of share that, because that's one of those barriers. But I do completely agree, like trying to have the conversation about this is for the kids and how do we coordinate for your children is a really good focus. So.
Thank you. And thank you, Kyla, for making that clarification. And that point. And thank you, Debbie, for what you said. Does anyone else have any thoughts or any questions for Pat or anything? Or experiences that you've had with this?
Hi, I'm Nancy with DD Vantage. I'm currently working with a baby who is in foster care. And there was multi-drug use during the pregnancy. And also the mom invited, the child has a diagnosis. I'm not going to go into details, but the mom invited physical abuse to try and abort the baby during the pregnancy. And my frustration isn't with DCFS, it's with the judge, because he is so intent on getting this baby back to the parents. And the reports that I've heard from the foster mom is that they just let the baby lay there while they're having their visits and nothing is done with this child. And it's just like in the last month, this baby is finally starting to come out of the withdrawals. For the first 2 to 3 months that we saw her, she kept her eyes closed. We weren't sure if she was able to see. We weren't, she does have some hearing issues. They just placed tubes. Hopefully that was going to fix the problem. They would put her on her tummy and she would just lay there. She wouldn't even try lifting her head. This last month, she was lifting her head, looking at the Christmas tree. She's looking at faces. She's starting to smile. It was just it was a complete change. It's a totally different child from when we were going the first few times. But it's just, for me, it's a frustration when you've heard what's happened to this child before delivery, and yet the judge is so intent on getting this child back to parents who didn't want her in the first place.
So there's a couple of legal reasons why. So federal and state law require a reunification goal if the parents want it, with the exception of if they have, there's a few exceptions, but 90% of the time they really are required to offer a reunification period of a year. If parents, now parents can choose not to do that. They can relinquish those rights at any point in time. But we have to be able to demonstrate that services was offered to any family or any parent who wanted their child for a minimum of at least, well, if they don't engage in anything, you can file within 3 months. But if they're doing some sort of services, they get at least a year to try to remedy whatever the issues are that they have prior to being able to terminate their rights. But a lot of our parents, especially ones who maybe really didn't want that child, will end up not participating in services or relinquishing their rights earlier on. And that just really comes from this unfortunate fact that we have some really great foster parents, but we also have a really high return of these fetally exposed children at about age 12. So our system is not super perfect. So even though we may adopt out a baby at under a year, we see a lot of these adoptions disrupt, because when they are 10, 11, 12, 13, a lot of these issues related to the exposure continue to show up in some processing disorders, some educational issues, some behavioral issues. And so nationally, there's really been this push that if at all possible, if you can heal the family system, these kids don't wind up back in foster care. We have a crisis in this country of kids with behavioral problems between the ages of 12 and 18 in foster care with no hopes of permanent homes. And so it's sort of this double-edged sword of trying to balance, like we want to definitely get them connected to as much as we can while they're little. We also have that long-term permanency to look at, because if they do come back to us at 13, 14, those trajectories are not great. There's just not a whole lot of people wanting to adopt a behaviorally difficult teenager. That's not there's not a line for that. So that's kind of the balance that the judges are trying to strike, and it's super frustrating. And it's why so much of the efforts are really trying to do even as much upstream as possible, as much as we can, screening prenatally, as much as we can, getting that, you know, parents into treatment before these kids are born exposed, or minimizing their exposure. Because yeah, once that steam train's going, it doesn't always have the best destination.
Well, can I just say I agree with you, because in my long life, I've seen that switch where there is a huge focus to reunite, and I am 100% behind that. I will do anything to help that family engage with their baby. And I think it's really, really important that they have the supports. That little case study, she is your kid. She has behavioral issues. She has a lot, but her mother loves her. Her mother that gave birth to her loves her and advocates for her with all her might. And so I think my focus is always on the parent. If they show an inkling of desire for that baby, then how can we support them?
I really appreciate that explanation about the reunification and what happens years down the road. You know, when we're seeing newborns who were exposed to multiple drugs, you know, right before delivery or for months before delivery, and the parents are lying about it and getting high in the nursery and all that, it's really hard to feel good about them staying together at that point. And more we're seeing you know, DCFS saying, oh, it's okay to go home, you know, with maternal grandma present or somebody to support that, and you know, coming around to that gradually. But it's still hard. But when I hear that kind of long-term rationale for it, it does give me a much deeper perspective on it. And so I really appreciate that.
Yeah, and one of the things that I would love, like what we're really trying and hoping to see, is getting more of the things like the residential that have the parents and children together. We have the 5 that are here in the state, and we do outcome data for them for some federal reporting, and we've been watching since 2018. And parents who actually engage in those parent-child residential programs with young children have about an 87% success rate at the 2-year mark of maintaining sobriety, of being able to have their child with them. And so we're really trying to see what are these programs that we can put people in as early as possible to really try to change that trajectory, so that you're not, I mean, it is very nerve-wracking when it's like, oh, they're still not doing really well. The other things that we really do have, the shift that you've probably noticed, is we really are looking for what are those other family supports, right? So mom might not be in the right place, but is grandma in the right place? Is paternal grandma in the right place? Is the aunt? So that they still have that mom to bond to, but they also have the extended family to help keep them safe. And then that just helps preserve those connections. Even if a parent can't get sober, can they stay within their own family system? And that has been a really big push in probably the last 8 years, 10 years in the child welfare system. And it's a little scary at first, just because I think there's a lot of inherent idea of safety taking that child into another home. But then there's some loss and some cultural loss and some other things that come along with it. So again, just trying to balance a double-edged sword.
Thank you for everyone that just shared. And I think that perspective and keeping that long-term perspective is very important. I mean, I'm not experienced at all in any of this, but just from what I've heard, and it just makes sense that that's, if you keep that long-term perspective, you're not just putting band-aids on and like trying to fix these problems in the moment. You're actually you're gonna make a bigger difference and set those kids up for better success in life and actually change it. So perfect. Does anyone else have anything to add? I am going to throw up a second poll. Just we're going to kind of start wrapping up here soon, but I'm going to launch that. And so if you can, while we finish talking, if you can fill that out. And the last question, I think it's question 6. It says to just answer it in the chat, and it's just about one thing you will change in your practice. So if you can just put that in the chat, that'd be much appreciated. And then if anyone has any thoughts, feel free to share. And Pat, thank you for your presentation. That was awesome. I think everyone loved and really appreciated the video and everything you shared. And it was awesome to see a real life example of what you were talking about and see how you incorporate all the things you were talking about into a real life practice. So thank you. I thought that was awesome.
Also, I've worked with Pat before. She's awesome. She's really great.
Yeah, she is. And also, Dr. Goldman-Luthi, she put in a link to the medical home portal page. So I don't know if you wanted to say anything about that link that you shared, Jennifer, but feel free to.
Oh, yeah, thank you. There's a couple of folks who've been working on a page that has summarized a lot of what's coming out of this series. It's really targeted at primary care providers and other professionals working with babies and children affected by NOWS or NAS. And so Dr. Stowers, who's on the call right now, has been working with Dr. Muniappa, who's been on before, and myself to make changes and try to pool these resources and insights from the whole series that we've had the pleasure of participating in. So the link to the medical home portal page is that. We will be updating it with information from the last few sessions, and that will probably come out in January. My hope is that we can send it out to this group via email. We'll see what we can do. And so I really appreciate it because it's kind of pooled learning from hearing what people thought were good resources and good points. It's been fun to pull that together as we go along.
Well, thank you. And that is such an amazing resource. So make sure you click that link and you share that with people you work with and use that. And thank you for putting in the effort to do that. So I think we'll go ahead and wrap up, and a few minutes early. Thank you for your time. Just wanted to remind you, this was the last session of 2021's Project Scope network. So make sure you register for next year's 2022. That link will be up on our website soon. And if you need access to Canvas, you can email Kurt. Kurt, do you have anything else to add?
No, I think the plan right now is to start the 2022 session in March. So if you don't get anything January or February, that's fine. We're going to take a couple months just to kind of regroup and get with our hub members and stuff. But yeah, any questions regarding Canvas, regarding red cap surveys, if you don't get them, just feel free to send them to me. Bailey and I try to coordinate so she can get the attendance in there, and then I usually try to get them in Thursday or Friday, but I've been a little late on last week's one. I just kind of lost track because we were doing a grant. But anyways, feel free to reach out to us. We just really appreciate all you guys who have been participants here and the hub members, and really thank you for helping share all that knowledge you have.
And there is a pediatric ECHO spring series, I think is what Dr. Luthi just said. So register for that. Do you have a link for that? By chance?
It's 2 up in the chat. The link went in first.
Oh, perfect. Okay. So if you want to register for that, go ahead and do that. Okay, but thank you so much everyone for joining and for all your participation this entire year. Like Kurt said, we're so grateful for it and grateful for Scope and this community we've been able to build. So have a great rest of your day and Merry Christmas. Happy holidays.
Thank you.
Goodbye.